Good morning, everyone. Welcome to another day of Future of Medicine. We'll give it just a minute for everyone to get joined to the Zoom call. A couple of reminders, make sure your full name is shown in your Zoom profile so I can take attendance. If you have questions and use the chat function, make sure to chat either the entire group or directly to me, because sometimes our speakers can't see the chat. You can also raise your hand and we'll call on you. And let's see, is our speaker on? Dr. Dougherty? Oh, I see you there. Okay.
Hey, Sam.
Hi. Okay, so our first speaker is Chief of Emergency Medicine at Sutter Medical Center, Sacramento, and he's also the President-elect of the Medical Society. So please welcome Dr. Adam Dougherty.
Hi, everybody. Great to be with you this morning and super excited and happy to share a few things about emergency medicine and my journey there and a few other fun things that I'm involved with as well. I've got a clinical shift a little bit later today too, so I'll be hopping right back into it. I live here in Sacramento in Land Park. My wife is a nurse over at UC Davis, and we've got two little kids, a 1-year-old and a 4-year-old, and two little doggies as well, and they all keep us very busy. But yeah, I'd love to share with you guys some of my passions, and maybe you'll learn a little something and get inspired along the way too. So yeah, we can kind of jump right into it. I am an emergency medicine physician. I'm the chief of emergency medicine. It's a 2-year rotating term, so you get to do some work within the hospital, dealing with other departments and dealing with the administrators of the hospital, like the CEO and the chief medical officer and chief nursing officer, to help deal with the many, many problems that we have within the hospital system and healthcare as a whole. Any questions at all along the way, feel free to drop something in the chat or go ahead and raise your hand. Happy to make this as interactive as we can, and then we can always leave questions at the end as well if something pops up. So next slide. So this is where I work, Sutter Medical Center, downtown Sacramento. If any of you have had the pleasure of coming to my emergency department or even in the hospital itself, there's a comprehensive women and children's center there. Deliver a lot of babies there in that hospital. We have a big pediatric and pediatric intensive care unit, big medical ward and ICU ward as well. We're not a trauma center. That's UC Davis, where I trained down the street a little bit, but we do get a lot of people that walk in with various traumatic injuries as well. So it's a very busy center, lots of patients. Sacramento's growing a lot. So we're basically just trying to keep up with the demand in the community. And it's a pretty great place to work. I'm not a Sutter employee. I work for a physician partnership called Dougherty, which is a physician-owned partnership. We basically staff all the emergency departments in the Sutter system, as well as Methodist and emergency systems as well. We have a great contract with the Sutter Health System themselves, and we're very, very close partners. So next up is, what do I do on a day-to-day basis? So the left cartoon there is pretty close. You're basically getting talked at by a dozen people every hour of every shift. There's a lot of patients to see. There's a lot of what's called triaging. You're trying to figure out who you need to see first, who you can see second, and who can wait a little bit longer, making sure you're not missing anything, getting updates on patients. Patients change conditions. Sometimes they get a little bit sicker, so you got to be a little bit closer to them. But, you know, basically the mantra is, the closer I am to you physically, is the sicker you are, essentially. If I only have to talk to you for a couple minutes, then you're probably, you know, going to be okay. And it's my job to figure out how that works and how to deal with all my consultants, like surgeons, with infectious disease doctors, cancer doctors, seeing if people need to get admitted to the hospital. You know, everyone from just people can't see their doctors in clinics, so they come to me, and we're actually very proud of that fact. On the right is what you might see in the many movies and TV shows that show a glimpse into our profession. That is emergency medicine. Sometimes it can be pretty bloody and gory. We're doing everything from setting bones to stopping bleeding to putting in tubes in different places all over your body if you're very, very sick. And sometimes this is the aftermath of it when, somebody needs to go to the operating room or upstairs to an inpatient bed and everything that goes along with that as well. It's it's a very high stress place. We are very fortunate, I think, even blessed to be able to take care of people in their, the worst moments, essentially, and that's a duty that we have. We don't turn anybody away, and we do, everything we can to the best of our abilities. But sometimes, the limited resources are a frustrating a reality of that. So on the next slide there, we'll actually jump into a quick video. If anyone has seen the movie 24/7, 365, it's a documentary about emergency medicine. And if you click that clip there, it will take us to kind of the preview or the summary of it. I thought it was a really good look into what we do.
I've often said that going to work is like reading a collection of short stories every day.
And I remember coming up to a patient, and she kept saying, "Sure enough, sure enough."
His father was screaming for help.
I had to tell her that he was gone.
You can't believe the gift that it is to be exposed to so many people's lives in such an intimate way. That's a powerful gift. And I think about that at the end of every shift. The emergency room really is the people's room. It's the place where they can come 24/7, 365 days of the year. Whoever you are, whatever your need, we're here to take care of you.
What we today know as emergency medicine and emergency care was essentially a room in the basement of the hospital where some suturing was done, maybe an asthmatic was treated.
What was it called in the early days? It wasn't an emergency room. It was called the pit. And that's what it was.
There were exposed pipes and dripping water, and it went into an area that had 4 little treatment spaces, basically a stretcher, and then there was a GYN room.
It sort of had a loading dock look to it, and over that it said emergency, and someone had tacked on a sign, if it's an emergency, ring the bell.
They were very small. They were crowded places.
Some actually thought we should decrease the size of the emergency department, increase the waiting time so people wouldn't come there.
Their opinion was, the ER is the best place to learn. This is where we've got to put the brand new doctors. They don't need supervision. They don't really need a specialist showing them what to do.
As a young emergency physician, I was scared because I knew how little I knew and how incompetent I was. My dad was 64 when he died of pulmonary edema. His cardiologist wouldn't come to see him when he went to the emergency department where he was cared for by an intern. The same year I was interning. I wouldn't have known how to take care of him.
I began to think to myself, there's got to be a better way.
What's the prototypical perfect ER doc? I've thought about that a lot.
Somebody who enjoys a lot of stress and never knowing what's going to happen the next second.
You cannot anticipate what's going to walk through the door, be dragged through the door, roll through the door, etc. And you have to be prepared for everything.
They've got to be smart. They have to enjoy adrenaline.
Adrenaline junkies.
Do you occasionally hit people? Yeah. Do they sometimes hit you? Yes, they do. Do you have to strap people down? Yep.
We act in an environment that is fast-paced and information-poor.
How much time do you think we spend with a patient talking to him in ER? 2 to 3 minutes, max.
If we were kids today, we'd all be diagnosed with ADHD.
Be able to leave one intense situation, walk over to the next bed, and not carry that with you, to be able to switch it off in the 10 steps it takes you to get to the next bed, because that person doesn't need the baggage of the other thing that you just experienced.
But then they have to have this other thing that is about having to make people feel comfortable really fast.
The humanity, the ability to be in a specialty where you get to interact with so many different patients.
We love the opportunity to be able to save a life. That's the most fulfilling thing that we do as doctors, and that's something we have the privilege of doing more regularly in emergency medicine.
We probably also drink too much and party too hard and do lots of bad things.
And somebody who can cry. If you can't cry, if I stop crying with relatives of the deceased, I'm going to quit.
Maybe not every day you get a chance to save a life. Sorry. It's actually my alarm telling me going on shift in a half hour.
So the gentleman in the middle of the clip there with the big round glasses and the big mustache, his name's Peter Rosen, and we consider him one of the kind of founding fathers of emergency medicine. It wasn't a formal specialty until around the late 70s, even early 80s. And that's when we came together and formalized recognizing the unique aspect that we play in the healthcare system. I actually had the pleasure of meeting Dr. Rosen when I was interviewing for residencies around the country. He was just kind of posted up in Arizona randomly at one of the residency programs there, just talking to all the prospective residents coming through. So I got to pick his brain a little bit, and he shortly passed away shortly after that, several months. So that's something that'll certainly stay with me for a long time. But it is kind of our, badge of honor. It's a stressful place for sure, but there's a lot of passion there, a lot of collaborative teamwork. I would say, some of the best parts are, of course, saving lives, but really the coworkers, the nurses and the pharmacists and the techs and case managers and social workers. We're just trying to figure out what the patient needs and what they need next. And, most of the time we're able to discharge people, but they come to us for a reason because they have nowhere else to go. So trying to figure out how to get them that help, especially now, in the wake of worsening mental health treatment and access across the country, substance use, and, the opioid epidemic, all these things, there is a huge role for the emergency department to play, I would say. We're proud to do that. Also, frankly, the lifestyle is pretty great. I don't have to work very often. I'm doing a dozen shifts a month, much akin to, nursing colleagues and other shift work colleagues, where I don't necessarily, need to be completely full time, and I can do some other things that I'm passionate about as well. And a lot of those other things that I do kind of intersect with the patients that I see in the emergency department. Basically, everything that is wrong with healthcare or even socially, in our society, whether it's homelessness or mental health or any number of issues, ends up in the emergency room. So I feel like I can, play a part in improving those things outside of the clinical things that I do on the walls of the hospital because I do have that perspective. Next slide, please. So just, as far as my background and how I get to where I am today, I grew up in the East Bay area in Concord. I went to De La Salle High School. And after I graduated De La Salle, I went to UC Santa Barbara, where I got my Bachelor's of Arts there. And I had the fortune to be able to do a medical Spanish immersion program in college, where I got to go live in Guatemala for a summer and help out and shadow in a hospital and riding around in their ambulances that they have down there. Got to learn Spanish. I ended up minoring in Spanish as well, which I use every day in the emergency department. And after that, I didn't really know, kind of what I wanted to do next. Sometimes that happens at the end of high school. Sometimes that happens at the end of college. Sometimes that keeps happening throughout, our lives. So, I was really trying to figure out, I knew I wanted to go to medical school, but not quite yet. I wanted to try and do some other things first. So I found what is called the Masters of Public Health. So you might have seen those letters behind my name at the beginning, an MPH program. So a master's program after you finish college. Some people do doctoral degrees like law school or pharmacy school or medical school. PhD programs or doctoral degrees. Master's programs are a bit shorter, but they are just as intensive and fill you with any number of skills in business or leadership. You may have heard about MBAs and MHAs, which is Masters of Health Administration. And MPH is that similar kind of time frame. It's a 2-year program, and it exposes you basically to everything in health that is not, clinical, essentially. So I'll show you a little bit more on the next slide here, what an MPH does and what public health is. So public health is basically everything. So, you guys may all remembered the pandemic. There was a lot of applications with public health there, whether it was dealing with population health around, exposures or vaccine campaigns, trying to get people vaccinated, or research, or, figuring out what to do when we run out of, toilet paper, or when we do, these things that are kind of external factors that affect us in different ways. So, public health is great if you're interested in nutrition, if you're interested in education, if you like numbers. Biostatistics is a phenomenal field. Public policy is the one I gravitated towards, and a little bit of a light bulb went off in my head, and I'll tell you more about that too. Global health. So diseases, they don't know, countries' boundaries or state boundaries. They're going to cross, that's how patient zero happens. And that's how we deal with things like malaria are popping up, or West Nile virus and mosquitoes. This is all part of public health. And in public health administration, which is, a lot of leadership, whether it's leading nonprofit organizations or leading the public health department in the different counties, thinking about how health systems can use the public health side for prevention and wellness, alternative medicines, finding ways to weave the best parts of what we've learned collectively to make people, not get sick. So, the drivers of health on the right side there, you can see the clinical portion, what I do in the ER, and what every other clinician does is only about 20% of your health, of your impact on your health. Your physical environment, where you physically are in space, is in effect, but the vast majority are your social and economic drivers. So the zip code you're born into, your family structure, your poverty level, all these things have massive impacts, more than we could even attempt to address at the clinical level. But we are able to, in certain instances, in the emergency department, thinking about some of those things, whether it's shelter, a roof over your head, or helping you get access to healthier foods or vaccines, or, an Uber ride to your clinic, appointment, for people who can't afford these kinds of things or have other social complexities that are inhibiting that. And then, of course, your health behavior, your wellness. How many steps a day do you get? Do you drink enough water? Do you lay off the sugary beverages? Do you the kind of the boring, eat your vegetables and sleep 8 hours a day? But, of course, there's a lot more to that as well. Any questions on the public health portion here? A lot of people, I certainly didn't know about that in high school or even college. And it's a cool, slant on, as opposed to, the kind of the hard sciences. If not, we can go on to the next slide. So this was kind of my light bulb moment. I took a health policy class in the MPH program. And I'm very kind of analytical, trying to solve puzzles and figuring out. I think that's why I went into EM, emergency medicine, because a patient comes to you and you don't know what's wrong with them. You have to figure out what's wrong with them, whether they're sick, whether they're not sick, and you don't really have any information. So you have to find the information to make a decision and solve a problem. So the big problem we have in the American healthcare system is, this is a very busy slide, but I'll try and break it down here. The bottom bar, that's basically how much each of these countries spend on healthcare per person per year. And these countries are kind of the biggest, most highest GDP. It's called the OECD, the Organization of Economic Cooperation and Development. Basically, the kind of the country club of countries. So a litmus test, a similar band of countries that we're dealing with. You can see how much more money we spend per person than any of these other countries. And those numbers in the boxes are rankings. One is bad, one is good, and 11 is bad. So there's a lot of areas of our healthcare system where we are in the last place, and we spend the most by far. That doesn't really add up to me. Why are we spending so much money in a healthcare system where our outcomes and our access are dismal? So our uninsured population. Why do we have uninsured patients in this country? We're the richest country on the planet. Why can't individuals get prevention and primary care in a timely manner? We do data well. We do expensive cancer care very well. We do trauma very well. But by and large, 90% of our healthcare system, we don't do very well. So, one thing that after the MPH program and looking into this, I went and worked in the health policy field. I lived in Washington, D.C. for a little while. This was during all the Affordable Care Act years, where we were trying to figure out how to insure more people and deliver healthcare more efficiently. So basically getting a bigger return for the dollars that we spend on those services, both from our own pockets and from taxpayer dollars. So after that, went to medical school, and I still stayed very involved in health policy. Living here in Sacramento, I've been involved in a number of state and national efforts with medical associations, with different groups around the country, doing a lot of storytelling and analysis and research and advocacy. So the next slide are just a few of the things. So we'll start top left. Last year, I got to testify in a Senate Health Committee around more common sense gun control legislation, actually calling for a constitutional convention at the national level. And California was the first state to ratify that, and I was asked to testify there. Top right was a few years ago, before I had facial hair. I was able to speak on the steps of the Capitol, the west steps of the Capitol, with a big group of doctors and medical students and nursing students and a number of legislators around increasing access for health education and loan forgiveness programs. Bottom right is with Governor Newsom that's my wife there on the left, and with Governor Newsom at his inauguration when he was first elected governor. And then bottom left was a recent trip with the Medical Society to Washington, D.C. This is the vice president's ceremonial office. We had some meetings with staff of the White House in the White House Executive Office building. So we got to attend there and really tell them about, the real problems we face in California and specifically in the emergency department around access to care issues, underfunding of public programs, and a slew of issues that really the future of our medical profession depends on. So next slide. So another thing I got involved in is I really like tech and innovation, and not just systems innovation around healthcare, but innovation in technology and education. And I got involved with a couple of guys I went to medical school with, started a company called Simex. So what this is medical simulation training. So instead of the big dummy that you got in front of you and you're doing chest compressions on, and we simulate just like flight simulators do for pilots, we do the same thing for nurses and doctors. And we do set up these big expensive programs and big expensive buildings to simulate an OR or a clinic, and you're kind of going through a case or a scenario with a patient. Basically, we've put all that into a VR headset. So we build the cases in the headset. You interact with the patient with your controllers. You listen and to their heart sounds. You ask them questions and they respond, and they can get better. They can get worse depending on what you do. So this was me a few years ago. I got to go to Shanghai and do a stage demo of our technology. I'll show you a couple of videos here. This was our kind of primitive technology before the Oculus Quest came out. But now yes, let's start that one over. And this kind of gives a good overview. And then I'll show you a cool one. We have some military contracts as well, because the military is really interested in delivering high yield simulation training, and we're a part of that as well.
Healthcare is one of the most critical and complex industries in the world. It requires continuous training to keep up with the latest advancements in medical science and technology, and it demands precision and accuracy in life-threatening situations. That's where Simex VR comes in. Simex VR is the most comprehensive virtual reality medical simulation training platform in the world. Developed by physicians for physicians, it offers the world's most extensive library of VR simulated patient encounters for healthcare providers, doctors, nurses, EMS, and military personnel. Simex VR enables teams to collaborate and communicate effectively, improving coordination and reducing error rates across multiple specialties and learner populations. Our patented software enables students, instructors, and observers to work together in the same room or from across the world and repeatedly practice complex procedures, not until they get it right, but until they can't get it wrong. Scenarios are immersive and engaging and provide powerful reporting and feedback to track learner progress. By directly addressing the issue of physician error rates, Simex VR is helping to improve patient safety and outcomes across the world and across multiple specialties with their accessible, immersive, and affordable simulated patient encounters.
So I was able to be an early investor in this company, as well as their chief medical officer for a number of years, and it has really grown. We have a full staff of data individuals and programming individuals who do the back end building of the program, as well as clinical individuals, nurses, retired military, and physicians to help make it all accurate. And we sell across the country to paramedics and nursing schools and medical schools. We're international now. We've sold to a couple health departments in Europe and Southeast Asia. And then we can do, if you have enough time here, just a couple minutes of that last video, and then I'll have kind of a punchline for you guys. I just thought this was a really cool video.
Military personnel need to be prepared to treat and stabilize a wide range of injuries across the continuum of care. But current training methods required to maintain medical readiness are expensive, time-consuming, and limited. To meet these challenges, Simex has developed the Valor program. This virtual reality medical simulation system is designed to practice clinical and operational decision-making in a fully immersive environment, while also saving time, money, and resources. Created with over $10 million in U.S. Air Force research and development funding, Simex is already in operational use at over 20 installations within the U.S. Air Force and Defense Health Agency. Virtual reality training offers huge advantages over traditional simulation mannequins, which are expensive, cumbersome, and very limited in what they can portray. With VR, the patient can be a warfighter with a traumatic brain injury on the battlefield, a local national with multiple traumatic injuries on a medevac flight, or a contractor suffering the effects of high altitude.
It's getting real hard to breathe.
Simulate the wide variety of training environments from the side of the road after an IED explosion to the inside of a CV-22. The SimX system can integrate any equipment, allowing institutions to match the sets, kits, and outfits that soldiers actually carry into the field, and can simulate patient care from the point of injury on the battlefield to definitive treatment at an MTF and every step along the way. With multiplayer capabilities, it allows teams to safely train in high-consequence situations while exponentially increasing reps. This allows military members to train not
Okay, in the interest of time, if you guys want to see more of the videos, just go to simx.com or their YouTube channel. We have a suite of videos there as well. But, kind of wrapping this all up, last slide, I would say, so I have my day job, right? And it's meaningful, and, I'm very lucky to be able to do it. But I also do other things that I'm passionate about. So, your calling and your passions, they don't have to be limited to just your profession. Think about the skills you have, the things you're interested in, and use them to think bigger. It's okay to have a plan, and it's okay for the plans to change. I know a lot of nurses who went to medical school. I know a lot of doctors who went into business. You develop skills along the way, no matter what you do, and those skills can translate across industries. So that's all I have. Happy to take any questions. And
yeah, we'll leave some time. Actually, our next speaker is running a little bit late, so if anyone has any questions, you can put them in the chat, or you can raise your hand about emergency medicine or about public health. Let us know. I wanted to ask, how does the emergency room handle mass casualties?
Yeah, so we have protocols for mass casualties. We have triage systems. We do trainings around it as well. So you're basically dealing with the sickest people first, finding the pathways to identify who's the sickest person, and just constant communication. And it's really an all hands on deck situation, where you have to be the calmest person in the room, and kind of being the quarterback for figuring out where the patient needs to go next as quickly as you can.
Yes, Mahar.
Typically, how long are the shifts, and are other doctors working with you in the area, or is it just like you on your own?
Yeah, so it really depends where you work. So at a busy urban hospital like mine, in the middle of the day, we have about 7 or 8 doctors on at the same time because it is so busy. If you're in a rural area, if you're up at Sutter Jackson, you're the only doctor on in the ER. It is kind of based on the volume. So, it's patients per hour is a metric of ours that, kind of defines the busyness of how busy the department is. So, for us, our shifts are only about 8 hours. And some very remote shifts in California and Texas, 24 hours. But you don't see that many patients. You get to sleep all night. You just got to be there in case somebody comes in.
Okay, thank you.
Sakita?
So, for as you're an ER doctor, did you have to take? You mentioned in your background in college you had a bachelor's in arts. So did you have to do prerequisites, and did you do your master's for to cover the prerequisites?
Great question. So, basically any preclinical education in college, and all the college advisors will tell you how to do it. You have to take a core set of prerequisites, and they're all pretty much the same. So that I had those all satisfied for medical school, essentially. The Master's of Public Health gave me a kind of a wider lens and a bigger expertise around healthcare delivery and health systems that I didn't necessarily get in the prerequisites for a clinical field, which are very hard sciences and a few other things that are involved with that as well. Emergency medicine itself, you don't really figure out what you want to do until you're in medical school. So even medical school is very broad until you get to your clinical rotations, and that, really you decide what you want to do based off what you like and what kind of lifestyle you want.
Thank you.
Sophia, we have time for 2 more questions. So I'll do Sophia and then Mia.
Hi, I'm just curious how you transitioned from going to like being like an emergency medicine like doctor or surgeon to being like the chief and being on the board of the like society. Like how did you transition that from more like the content based to including the like management like side?
Yeah, another great question. You guys are smart. So it's really, I started early, and I would say I had experience between um, medical school and everything, my education before that, to be able to get involved in other ways and be a leader in other ways. And, I essentially did it while going through medical school and beyond. It's very easy to kind of sit back and say you're too busy, or you have too many. And it's good to have boundaries. You can't be too busy. You got to get get your stuff done first. But if you can kind of factor in other things and gain positions along the way and put yourself out there a little bit with the skills that you have, you learn along the way. You get better self-improvement around leadership and organization, and it lends to new opportunities, and it's kind of up to you to be proactive in those opportunities.
Okay, thank you.
Sure.
Our last question's from Mia in the chat. If you're not an employee at Sutter, how did you apply for a job there?
Yeah, so you basically, so it's a little unique. I guess the comparisons would be Kaiser and an academic center like UC Davis, where you're actually employed by both of those. So instead, who I applied with was Vituity, the organization. You can Google them as well. They do a number of other. We have anesthesiologists, we have neurologists, we have surgeons. We have ICU doctors as well. So you basically apply to the site, and each site has a partnership team. So you apply to the medical director of that team site, essentially, and then you get to join the greater partnership, which is we're in a number of states now.
All right. Well, thank you so much for being on the call. This is great. If anybody has any follow-up questions, I'll be in touch with you. But thank you so much for spending your morning with us, and have a wonderful rest of your day.
Of course. Thank you guys so much. And yeah, please, Sam, pass along my contact info if anyone has more questions or more info.
Thank you.
All right. Have a good day, guys.
All right, our next speaker, we're going to hear a little bit about community health careers with Adriana Aguilar, and she actually is, and Dr. Dougherty mentioned his MPH. She is in the process of getting her MPH as well. So she's the program manager for Spirit here at SSVMS. So welcome, Adriana.
Hi, good morning, everyone. Thank you, Sam, for the introduction. Like Sam said, my name is Adriana, and I am part of the Spirit program. We'll talk a little bit what the Spirit program is. We're actually part of the Medical Society, so I work alongside with Sam. But really what I do in my background is community health. So that's really what I'm going to talk to you guys about, what's community health, in my experience in working in community health and how I got there. Screen. So a little background on me. Like I said, my career, my background is in community health, so I do consider myself a community health worker. My education, I started off in my bachelor's actually at Sacramento State. I worked my bachelor as community health education, and I am currently doing a master's in public health. a master's in public health, there's different focuses that you can do. You can do master's in public health in continuing with community health, master's in public health with data, and so my specific focus is master in public health and epidemiology, where you look at um, kind of all the diseases that's going on right now, especially for example COVID, and seeing how it started, why it's happening, how you can stop it. But it is a focus. It is still considered public health, with my background in community health. So what is community health, and why is it so important? Community health focuses on just the overall being of the community you are with. So I think it's really important that when you when all these providers they work with the patients on an individual level, but you really want to see what a patient's surrounding environment looks like. What are they eating? Where do they live? What's their education? Because all that really impacts their health, what the community health is. And you can do so much in community health. Really, what community health means is just equal access to healthcare, to making sure that everyone has employment, transportation, nutrition, healthcare. It's just the balance of everything that makes you healthy as a person. So as a community health worker, your focus is to make sure that the community and the people that live in the community have access to these services. Because in reality, we live in a world that communities, individuals do not. So community health worker, you're really focusing on that and seeing how you can help individuals within the community. So a lot of these roles, that I have that through my roles that I've been able to advocate and help patients is really being able to help people get the care they need. Again, access to care, access to nutrition, access to transportation, access to medication. And you're working with individuals and families in the communities, right? So sometimes you're working with them on an environment which is more clinical, which I'll talk a little bit more of that with my experience working as in a healthcare setting. Or sometimes working out there in the community. You're going out there to help individuals who are homeless, for example. That's just an example. So really, you don't have one environment that you're working with these individuals. You can work with them on any set of an environment, may that be in a clinical setting, may that be out there in the streets. Um, and one of the important things is, as you know, is we live in a world where we have so many different cultures, so many different languages. So it's very important that when you do work with the individuals within the community, you are trying to understand where they're coming from, because not everyone has the same experience as you, and everyone has the same experience as your friend. So when you're working with different communities and different individuals, you want to make sure you're helping them within their own environment, because that's how you're really able to make the biggest impact. And of course, a lot of these communities we work with are low income individuals, low income families, so they don't have access to food, they don't have access to transportation. So as a community health worker, that is one of your goals, to be able to increase that access. One of the things that I personally have done as a community health worker, and I continue to do, is I work with federally qualified health centers, closed or FQHCs. So what federally qualified health centers, they work with patients or individuals who are low income. They work with families who are low income. They see patients and families who have Medi-Cal and who have no insurance. And for those who don't have insurance, it's based off their income. So sometimes you only pay $10 to see primary care because of their income. And you will see community health workers that work within these clinics. And that is something that I did myself. I worked with individuals that within FQCs, I was a patient advocate, and I helped them get free medication, transportation. They would come in with bills. They would go to the emergency room. Would be uninsured. They come with bills that were like $35,000 more, and I would try to get them cleared. So you really are working with them to try to just increase access to care and help them just live a better life as much as possible. And as I am a Spanish speaker, I was able to help a lot of the Spanish speaking patients and work with them on that level culturally, which a lot of times if any of you speak a different language, if your parents speak a different language, sometimes you are the interpreter, because they are unable to speak to doctors or nurses or front desk because they don't speak their language. So for someone to come in, speak the language they speak and help them go through whatever they need, sometimes it's something as little as that, and you're making a huge difference. These are some pictures through my past experience as a patient advocate, and I was actually a diabetes health educator. So these are my past patients, and these were patients who had Latino background, and I helped them through manage their diabetes. If any of you know, diabetes is very common in the Latino population, and sometimes just educating them on what they can eat, what they can't eat, and helping them through the process. That's also part of being a community health worker. And this picture is just them, the certificate of completion at the end that they were when they went through the program. This is another picture from one of my internship actually when I was finishing up my bachelor's in community health at Sac State. I had to go out and work with Communicare. If any of you are have live in Yolo County, have family in Yolo County, it is an FQHC, a federally qualified health center, in Yolo County and surrounding counties. And this specifically, I was working with a prenatal coordinator. So these are, and this coordinator was helping low-income mothers. So these are mothers who don't have access to food, to Pampers. So I was helping with an event and trying to get donated supplies for their babies. And now I am currently working with the Spirit program. So the Spirit program, we're actually part of the medical society. And like I said, I work with Ronnie and I work with Sam and my coworkers. And just like the Future of Medicine program, we are a nonprofit program. Our mission is to increase access to specialty care to low-income individuals who are uninsured. And specialty care essentially is outside of primary care. So patients, if you ever had a family member who needed to see a doctor because they were having stomach issues or because they had a hernia or they needed a colonoscopy. These are specialties. So they need to go to a provider who specifically was able to go through the background education to help that specific area of expertise. I mean, sometimes unlike they go to federally qualified health centers where they get free or low primary care, but outside of that, if they need specialty care, they have to pay out of pocket. And a lot of times it's $10,000 to see these doctors because they're uninsured. So this is where Spirit program comes in. We connect them with our wonderful volunteers with our specialties to doctors, and they do free surgeries for us. So we have a lot of patients who are low income, don't need care, and we get them free surgeries. And these are just examples of some of those specialty cares that we're able to get for our community in the area. And we've been able to help over 55,000 patients. They have received free specialty consults and they have received over 1,600 surgeries as well. And we help with translation, interpretation. We help with insurance as well. We have had patients who unfortunately has been diagnosed with cancer, and we try to help them through the process as well. So as community health workers, that's another thing you do. You help them navigate the system. And by the system, I mean the healthcare system can be very complicated. Sometimes it's just as easy as calling a clinic on their behalf because they speak a different language and you're able to speak English. So something as little as that can make a difference for the patients. And these are some just pictures of our patients and our wonderful doctors and volunteers that we worked with. They provided free glasses, free vision exams, free surgeries. And these are our patients, our wonderful patients that without our doctors, and future doctors, as yourselves, we're not able to help the community. We're not able to make a difference and try to get these patients the free care that they need. And my contact information if you guys need or have any further questions after the presentation. And I know Sam can also give you my information.
Thank you. We had a question in the chat. Do these primary care providers have MDs?
Have what? I'm sorry?
MDs?
MDs?
Yeah, are they're doctors?
Yes. So primary care doctors, there's different levels of primary care. They can be medical doctors. They can also be, we call it's, but they're better referred to as medical providers because it's based off their education and what their title is. MD is just one of them. There's mid-level providers such as nurse practitioners who don't have as much as education as MDs do. They don't have to go through that school, but they get less schooling, but they are able to see patients and they work under MDs. I'm not sure if any NPs or nurse practitioners or PAs will present to you guys, but those are considered mid-levels and they usually work alongside the MDs are in their part of the team. So they're healthcare providers and they are able to see the doctors. And there's mid-levels also through specialties. It's not just primary care. They can also work on a specialty level.
Another question. Were you a medical assistant or a medical student?
I was not. I actually initially, before I got my bachelor's in community health, I was pre-nursing. So I did take a lot of those classes such as anatomy, chemistry, microbiology, all those very fun science classes. Because community health and pre-nursing have the same prerequisites. So if you're trying to get into those programs, you have to take prerequisites in order to apply for those programs. And the nursing program and the community health program have the same prerequisites. So I was very easily able to transition in. So I don't have the medical background. I did take those classes though, initially as if I was going to. But a lot of times it's experience. You work on a clinical setting, you work very closely with the doctors, and you really get to learn a lot. As a community health worker, you really learn how the healthcare system works and how to connect the patients to resources and doctors and clinics. And when you do that, you're like a sponge. You work very closely with medical assistants, with doctors. You really get to learn a lot. So you don't necessarily have to have the background so you don't necessarily have to be a medical assistant to be a community health worker. Obviously, if you do get to it, it helps a little, but you're in the trenches with the patients. You help them. You are trying to navigate and connect the patients. So you get to learn a lot and you work very closely with the doctors, super closely with the doctors in their volunteer office and their staff. So you are able to gain a lot of that medical knowledge in order to be able to help your patients.
Do you work with counties like government?
We do. We work with Sacramento County. And federally qualified health centers, they're considered a government entity to an extent because they are actually funded by the government. So we work with government-funded clinics, such as federally qualified health centers, and we work with Sac County, and Sac County has their own clinic. So we work with government-funded programs and government-funded clinics.
Does anyone else have any questions for Adriana? Well, I have your contact information if anybody has any other questions. And I will provide that to you guys so you can email Adriana. All right. Well, thanks for being on. I appreciate it.
Thank you guys.
Yeah,
All right, good luck.
thank you.
All right, bye.
Bye. Okay, we're going to take a quick 5-minute break and be back here at 11:30. You can turn your cameras off, but don't log off. All right, welcome back. So our last speaker is on. She is also with the Medical Society. Amber Arif is the program coordinator for the Sacramento County Opioid Coalition, and she's going to introduce you to some of the pathways in harm reduction. So welcome, Amber.
Hello, thank you so much, Sam. 1 second. see, I wanted to switch to my webcam because my laptop camera's kind of garbage. Okay, let me share my screen. Okay. Sent. Sent. Okay, can everyone see it?
Looks good.
Full screen? Okay, great, awesome. So yeah, my name's Amber Arif. I'm sure some of you have seen me before, but I will be kind of talking to you about my pathway and other potential pathways you can go through in regards to harm reduction. So, I mean, back in high school, I was not very familiar with the term of harm reduction. So, I think it's important to kind of talk about what it is and how important it is in the healthcare and just like the public health aspect for sure. So what is harm reduction? So the concept of harm reduction is basically, if you want to put it in general terms, it's just addressing broader health and social issues through improved policies, programs, and practices. That's kind of the general way to put it. But basically, when it comes to harm reduction, a lot of the focus is on substance use, mental health, and specific diseases that are kind of more of a public health concern. So the one that I have focused on, given that I am from the Sacramento County Opioid Coalition, is substance use specifically. So what I do, or what people who are in harm reduction do, is that they kind of work with these people directly or work with policies directly, but you work with people who use these substances and kind of help them and give them some sort of tools and resources and information in order to create some kind of positive change in their life and potentially save their life. So anything that kind of brings any sort of benefit or increases their quality of life. That's a very general way of saying it, but I will have some examples, of course. A lot of harm reduction is very community driven and very public health strategy. So this isn't necessarily a very like clinical aspect where you're in the hospital at the emergency department saving lives and things like that. It's very getting your hands dirty in the community. You're working with a lot of members, a lot of people who are affected by substance use or whatever public health concern you may have. And there are many ways to kind of you know that harm reduction kind of encompasses. So harm reduction isn't necessarily just the idea of like telling people who use to stop, right? Like, trying to give those people resources. It's also prevention. It's also education. It's also risk reduction. So people who may use, but they may not be able to get the treatment that they want right now, what can I do to prevent them from hurting themselves further? For example, so for opioids, right? Opioid overdose is such a huge problem. So what can I do in order to reduce opioid overdoses? And one of that is Narcan. So Narcan is a really important way of harm reduction and risk reduction. Anti-stigma. The idea of anti-stigma is people may use, each of them do have their own stories and things like that. And there's a lot of background behind as to why some people may be using. And we like to kind of get rid of that stigma. The idea that like all people who use substances are bad, right? Because that's going to scare people away from getting treatment, getting help, getting resources, getting any sort of support from, the community, their family, their friends, and things like that. So that's why we really strongly believe in anti-stigma, so that these people are able to come forward and get the help that they need. Health promotion. Health promotion is also very important, but this overall is to basically empower these sorts of people, and it kind of provides them these choices so that they know that they are able to live healthy, self-directed, and purpose-filled lives. So kind of get them back up on their feet, but not necessarily in a forcing or judgmental way. So as I mentioned before, you basically engage directly with people who use, and the community is greatly affected. So when it comes to substance use and opioids and fentanyl use specifically, we are seeing a lot higher opioid uses and fentanyl poisonings specifically in lower income communities or in minority communities, even the immigrant community, specifically because sometimes dealers tend to target people who may have like a very strong language barrier and things like that. So there's a lot of different communities that you do have to work with for sure. So the idea is rather than just kind of sending them to a recovery center or telling them to take this medication to make them, stop using. You want to kind of improve their overall, it's like a holistic kind of approach. You want to improve their physical, their mental, their social well-being, because there's more than just like sending them to a clinic or sending them to therapy. So it's definitely a lot more than that. So we want to also make sure that, like, unfortunately, the American healthcare system does have a lot of barriers, and sometimes it's very expensive for people to get treatment, even if it's not even just substance use, but for like other things as well, as you guys probably know, insulin, chemotherapy, surgeries, all sorts of things. So the idea of also harm reduction is working with the community to kind of break these barriers and offer these low barrier options for healthcare services. So kind of working with the community and seeing where they're at and seeing what we can do to kind of offer things for free. Like, that's why there's community clinics, and that's why there's harm reduction services, and that's why some places offer free Narcan, like us, and things like that. And then last but not least, but like the quote that a lot of people like to say is meeting people where they are on their own terms. And the idea of that is we're not trying to force or basically force anyone to kind of seek treatment immediately. It's more of for people to kind of get know that they have the resources available to them and kind of be a support for them, no matter what they're doing right now. And when they're ready, we will be ready for them to give them whatever they need in order to recover. So that's the idea of harm reduction. I know it's kind of like a lot, but I do think it's a really important part, especially in the public health and like community health area specifically. So where can you work? So if you want to do something related to harm reduction, there's a lot of places where you can work. I honestly kind of would say that, like, it's kind of, I wouldn't say unlimited, but there's a lot of different places you can give a shot. So one of them is the government. Specifically, Sacramento County has the substance use prevention and treatment department. And we work with them a lot as well. And a lot of them are really big on harm reduction. A lot of them help with Narcan distribution, community events, and things like that. The public health department is also really big on that. They also like to educate their employees and the community about the dangers of like opioids and fentanyl, but also being a resource for people who may be using, or even family members who have lost someone or are dealing with someone who is using substances. Another one are community nonprofits, or just nonprofits in general. So for example, I am with SSVMS, which is a nonprofit. However, they are the parent company to what I'm doing. So I am with the Sacramento County Opioid Coalition. So in a way, that for us is a community nonprofit because we have a coalition. We work with a variety of different communities and things like that. So there's a lot of nonprofits out there that actually do a lot of the work that are kind of like opioid coalitions or some kind of substance prevention nonprofits, and all those things like that. A lot of them do participate in harm reduction. The third one is obviously harm reduction clinics. There's a few of those in the Sacramento area. One of them is harm reduction services, and the other one is SANE. Those are the main two, but they provide a lot of resources for people, and most of them are free for those who are looking to, either get some kind of treatment or try to reduce risks of, like, using substances and things like that. So they have a lot of information and resources, and that is definitely somewhere where you could find work. Last but not least is behavioral health. It's kind of like a big umbrella. So that could either be if you want to work at a recovery center, if you want to work at a community health hospital, or if you want to do social work. There's a lot of different things you can do that are definitely related to harm reduction, because addressing behavioral health or even working in that kind of recovery aspect is a part of harm reduction technically as well. So for education and experience, I'm going to be honest, I'll tell you next slide about like what I went through, but I would say harm reduction is very forgiving when it comes to education and experience. I don't think it's as important, at least for schooling, but if you are set on this is what you want to do, or at least you want to focus somewhere in the public health aspect, I would probably recommend going for like some kind of health education or public health degree, but other things that work as well are social behavioral sciences, biostatistics, sociology, psychology, all sorts of basically any sort of like health related degree, which is probably what most of you are looking at, potentially for other reasons, but that will probably get you closer to probably what you would want. Experience, I think the best experience you could probably get if you want to do harm reduction would be volunteering. It's because with harm reduction, you're working with a lot of different communities, a lot of nonprofits, a lot of underserved communities. So I would say that volunteering with like different nonprofits, different community organizations that are, local to you and things like that, I was lucky that I got to volunteer with Volunteers of America, and what they let me volunteer is that I got to work at a recovery home specifically for mothers dealing with drug and alcohol use, and I got to talk to the mothers, and I got to plan projects and like arts and crafts and things like that. But yeah, like that was a kind of like a big opening experience for me, and I think that is honestly what landed me this position. So those types of volunteering activities definitely will give you that experience and also let you decide if that is something that you want to do. I mean, work like that is always going to help the community, so I don't really see any harm in doing it. Behavioral health work, and then one thing that I kind of think is important is for harm reduction, you're doing a lot of projects, you're doing a lot of administrative work. So I think if you have any sort of administrative background or some kind of way that you want to kind of get your way into the, I don't want to say industry because industry sounds wrong, but like if you kind of want to get into that field of work, I think being an administrative assistant or some kind of doing some kind of administrative work would be really beneficial because you do have to do a lot of writing. You do have to do a lot of communicating, and you have to do a lot of projects, organizing projects and like figuring out meetings and schedulings and things like that, which is like a lot of admin work for sure. Background, I think the main thing about a lot of people going into harm reduction, their background is mostly based on personal or lived experience. And that basically means that they know someone near and dear to them, or even themselves have been dealing with substance use or something similar, where they think that there is a need for harm reduction in our society, which is, I think, probably the most powerful experience you can get because you're the one experiencing it or witnessing it firsthand. Empathy is very important for harm reduction. A lot of people that you're going to be dealing with are going to be either dealing with loss or in the process of dealing with someone who is using substances or are using substances yourself. So it's very important that you do have a strong sense of empathy and understanding for what a lot of these people are going through. And even if you can't really, you know, understand it from a personal perspective, at least be somewhat sensitive and understanding and be willing to listen to a lot of these peoples, because a lot of them do have a lot to share, and a lot of them have really big stories and things that they want to talk about. So it's very important to be empathetic. Willingness to keep learning. So harm reduction is definitely a relatively new field of work. Yeah, I would say it's probably like relatively new, at least in the healthcare aspect. A lot of different communities actually don't really, you know, participate in harm reduction. Fortunately, Sacramento County is really big in it, and a lot of counties and areas in California are really big on harm reduction. So it's still a very evolving field. We're still getting resources and statistics and things like that. You have to kind of stay up to date on things like that. So willing to keep learning about that. There's always new substances coming out, new statistics, new every year there's like an annual report like, oh, this is what's happened over the past year in the county. Sometimes there's like new things that happen. So it's always good to keep learning, stay up to date on like policies and laws and things like that. Last but not least, an interest in public and behavioral health. I think that's pretty important when it comes to harm reduction, because that is kind of like the most adjacent thing I can kind of kind of associate it with, I guess. Okay, so as I mentioned, I do work with SSVMS technically as a program coordinator, but I am technically the program coordinator for the Sacramento County Opioid Coalition, which is under SSVMS. So I got my bachelor's in science in health sciences, and my concentration was in biopsychology. I actually got it from, I'm sure you guys are familiar with the school, but California North State University. So when I first went to university, my intention, or at least I was supposed to go into medicine. So my goal was to become a doctor. This was heavily based on like what my parents wanted for me. They thought that was best for me. Of course, because I came from like a very strong immigrant family. So medicine was like, you know, #1 priority. But for me, clinical sciences was never like my strength. So I actually did my bachelor's in health sciences. It took me 3 years. I graduated in 2020. And then I actually took the MCAT and everything like that. And I ended up going to the medical school for about 1.5 years. So my pathing is definitely very weird and very not normal for like harm reduction. So I did go to medical school for about 1 year and 1.5 years, and I did have really bad burnout, and it just wasn't really aligning with what I truly wanted to do, you know, for the rest of my life. I just could not, like, I'm not trying to like push anyone away from medicine. This is a personal experience. I just realized that medicine was not for me. I have a lot of friends in medicine right now. Some of them are graduated, some of them are doing fantastic. They're like, they love medicine. So it just wasn't for me. So I took some time off. I worked as at a lab assistant at UC Davis for a while. I also did some administrative work for a different company in the Bay Area for a few years and things like that. And then in college, I did a lot of volunteering. So I did a lot of volunteering at Volunteers of America. I also did some volunteering at some community clinics when I was in medical school and before that as well. A lot of different nonprofits and things like that. I kind of got to work with a lot of the Sacramento community, and I fell in love with the Sacramento community and understood that substance use was a really big problem. Specifically, I guess the best way to put it is kind of like an epidemic. We call it the opioid epidemic. So that's kind of where I kind of stumbled across this position. And I kind of thought my experience at Volunteers of America and the community clinics at Shifa and Tapati, that I kind of realized this is something that I could probably thrive in more. So my goal is to kind of stay within the harm reduction field, whether it's substance use or something else, but probably I do hope to get my master's in public health starting next year. So that's kind of how I got here. So I know it's very unconventional and it's kind of all over the place for sure. Like I did not expect myself, like if I look back at myself like 4 years ago, I would not have seen myself here, but I'm happy with where I am. And I think the work that I do is good because I personally feel like after I finish a day of work, I get to go home and kind of feel good about myself. Like, you know, I did this today. I'm working on this project, which I know is going to benefit a lot of people. So who do I work with? This is kind of important because there's other people that also do harm reduction, as I mentioned, but let's talk about like the specific positions and people that I work with. So a lot of physicians, I do work with a certain amount of physicians. So either if I want them to be guest speakers or I want to have meetings with them and talk about different pain management things, or like they want to do classes and things like that. Emergency doctors, a lot of them do a lot of incredible research on fentanyl and opioid use. So I do talk to a lot of physicians on that, and they share me like, you know, their statistics. We just recently created a database for emergency department visits in the county of Sacramento. And it's like updates in live time, and it has every suspected opioid overdose recorded, which is really cool. But we work with a lot of physicians and other healthcare workers too, like nurses, PAs, whoever's interested in kind of joining with the opioid coalition. A lot of behavioral health workers, which I'll go into later. Community leaders and nonprofit organizations. So as I mentioned before, not necessarily just nonprofits that focus on recovery and things like that, but I also work with a lot of community leaders and nonprofits that focus on youth, that focus on the Black community, that focus on the immigrant community, that focus on the Hispanic community, all sorts of different organizations, because a lot of them do have that outreach for, you know, the community that they're trying to reach out. And what we want to do is kind of work with them and kind of figure out like, hey, we want to, you know, educate, you know, this community on opioids and fentanyl, how to use Narcan, blah, blah, blah. Would you be interested in like working with us? And a lot of times we do establish like this good relationship. And a lot of them also are very familiar with their community, and they talk about, you know, like, oh, you know, this member from this community the other day, their son passed away from fentanyl. Are you interested in, you know, like giving us some resources to them and things like that? So we want to make sure we have these solid relationships so that we're actually, you know, our hands are actually in the community rather than just kind of sitting up top and just like, you know, we work a lot with the government. So specifically the Sacramento County, as I mentioned, the Substance Use Prevention Treatment Department and the County of Public Health. The SUPT, we work with a lot specifically. A lot of our executive committee members work there. A lot of them do social work. A lot of them do behavioral health. A lot of them do have, they do their own like Narcan training, community events and things like that. So we work a lot with them side by side, and it's really good to kind of have that hand in the government or in the county, because a lot of them also do have really good connections as well. And we also do have partnerships with the library, the coroner's office, different social workers, the police department, actually, the fire department, the EMS, some EMS branches as well. So we're kind of trying to make sure that we have, we work with basically everyone involved in the government, because, you know, we're trying to reach out to as much of the Sacramento County as possible. We also work with behavioral health workers and organizations. So for example, recovery centers, like Fair Oaks Recovery Centers, Monarch Recovery Centers, like all these sorts of people that are basically treating either giving treatment or some kind of therapy or support to people who are using substances, specifically opioids. And last but not least, we do work with a lot of schools and universities. So for example, we are working with CRC right now in helping them with getting Narcan for the entire community college. We are working with Sacramento State University in our upcoming fentanyl summit and planning that because they've let us use their venue and things like that. But we are also making sure that they are also up to date on their Narcan training and fentanyl training as well. We also work with medical schools. And what do I mean by that? Because medical students, you know, doctors are the ones that tend to prescribe opioids. So we think it's really important to teach upcoming medical students on Narcan, how opioids really are, alternative pain management if possible, and things like that. So we are currently working on a project to kind of educate, you know, the doctors of the future, which might be you guys as well. Okay, so all this yapping, but what do I really do? Like what does it like look like for me if I were to, you know, if I had a different job interview per se, they asked what I did, right? What I put on my resume, right? I kind of tried to divide into 3 things, but I feel like there's still a few things that are missing, but here are the main things. So number 1, community outreach. Really big thing about community outreach is establishing these partnerships with these nonprofits. As I mentioned before, that the target diverse communities. So making sure I have these partnerships with, you know, with like youth organizations or Black Youth Leadership Project or Impact SAC and things like that, and making sure that we have this connection. So whenever they have any upcoming events or they have any, you know, families that are affected, that we can offer resources for harm reduction, opioid education, naloxone, also known as Narcan training and distribution and things like that. Managing and developing projects. So a lot of that is we do a lot of projects, of course, as a coalition. So a lot of that, my work is basically planning and coordinating these events along with one of my coworkers who's a AmeriCorps volunteer. So some of the projects we do is Here to Heal, which is a monthly group support for those who have lost loved ones to opioids. Gone Too Soon, which is a poster memorial project for those who have also lost loved ones from opioid use. Naloxone training and distribution. So that is actually what I'm going to be doing on Thursday with some of you guys. And I also think I did it last week. No, not last week, week before that. Sorry. But we do give out Narcan to the community during community events or people who just email me and say, hey, my organization wants a Narcan training. So that's what I normally do. We have our quarterly meetings, and then we also have our annual fentanyl summit, which is like a full day of different guest speakers who are educated on fentanyl and opioids and things like that, and kind of like, you know, kind of telling us like what's going on this year, anything new, like polysubstance use, like meth and fentanyl, like what's going on with that, for example. So a lot of projects that I'm working on, and there's a lot more to be done as well. And last but not least, as I mentioned before and emphasized really importantly, there's a lot of administrative work and social media. For the most part, I'm kind of the main contact person when it comes to the opioid coalition, since it's pretty much the 3 of us that kind of like do a lot of the bulk of the work here. So I'm the one that kind of does the scheduling and coordinating the meetings. I'm maintaining the website, making sure it's updated every single time we have like a meeting. I have to make sure all the slides are posted and everything like that, and making sure that it looks nice and everything. I also have to create video and graphic content for social media. It's not necessarily, I would say video content is definitely a lot harder given I have a lot more other things on my plate, but at least try to have more social media content so that it's more informative for people who are just looking for information and things like that. Communications and email, so just establishing a network with people, and then also making sure I'm up to date with emails, because people email me about Narcan or about upcoming projects or upcoming meetings and things like that. And then last but not least, research grants and progress reports. One thing about working in any nonprofit is if you are some kind of project coordinator or a manager, you will have to kind of worry about grants and progress reports, because you do need money. You are a nonprofit. So understanding how to write those grants and how to you know, send those regular progress reports to make sure these people who are sending you this money know where it goes. So that's also a big part of what I do. And I think with that, I think I made it on time. So I would like to thank you guys for listening. I know harm reduction is definitely a very different topic from, you know, a lot of other things rather than just like medicine or public health. So if you guys have any questions, feel free to ask me.
There was a couple questions in the chat. Let me pull that up. Let's see here. How do you keep yourself safe when you are working with those who do substance abuse?
So, I guess that's a very valid question, but it's also a very complicated question. I think one thing about substance use, is that, you have to kind of know. So specifically, for example, one thing for being in the opioid coalition is a lot of people are scared about like fentanyl, right? And fentanyl can be found in like a powdered form, and people see like these videos on social media and they're like, oh, like I don't know, I don't really want to like, be near someone who has like this powder because I don't want to end up ingesting it on accident. It's more of like a matter of educating yourself and making sure like, okay, I know I can't touch the fentanyl. I should avoid touching the fentanyl, but if I do, I won't overdose. I just need to wash my hands with soap and water, for example. And sometimes people who may use tend to be a bit more unstable and things like that. And that's not necessarily people I work with. Necessarily, that's more for people who do like social work and behavioral health, I would say. And for those people, they are specifically trained in understanding how to diffuse situations and kind of how to deal with that. For sure.
Okay, another one in the chat was, what are some symptoms of opioid use? Is it worse or better than pretty bad drug meth? I don't know much about drugs, and so I'm curious which drug causes the worst symptoms and is most fatal.
So opioids and meth are very different types of drugs. So meth is a stimulant, as in it kind of causes people to be more alert, I guess that's the best way to put it. And opioid is more of a painkiller. So painkillers kind of, it makes you feel more numb, more relaxed and things like that. So the dangerous thing about opioids specifically is that opioids are very addictive. And since they're so addictive, they're very easy to overdose on. And overdosing can potentially lead to you dying. And opioids tend to be the most dangerous because you can overdose way quicker or way easier than meth or cocaine, for example. They're both extremely dangerous. They both have completely different effects on like your health and things like that. Like both of them will still be detrimental to your health for sure. But those are like the main differences, I'd say, that you would probably need to know.
Sophia.
I just had two questions if we have time, but my first was, so you mentioned the progress reports. I was just wondering how you measure like how much like harm you've reduced or how much of an impact you've had on like the community. How do you like measure that or put that into data?
Yeah. So what we do is we record the number of like Narcan kits that we give out, for example, because that is the method of harm reduction, and then the amount of trainings that we do and how many people were there, right? We also record a lot of the meetings that we have and write them down like, hey, we met with this person, this person, this person, and we're planning on doing this, this, this. So it is definitely, you do have to keep track of like every little thing that you are doing. So one of the main things is just like kind of writing down the numbers of like, this is how many people that we talked to, this is how many people we reached out to. And sometimes we have to do surveys and things like that to make sure that like these people are like understanding and like that they're like, yes, I know what you taught me today. And like, yes, I am aware that fentanyl does this, this, this. So that is like the main way that we do that.
Okay, thank you. And then I just had another question. Are there any like nonprofits or volunteer organizations that you would recommend for high schoolers in like the Sacramento area that come to mind?
Unfortunately, I did not grow up in Sacramento, but I am definitely willing to kind of take a look at what organizations are looking for volunteers, because we do work with like a number of organizations that are that work with a lot of high schoolers and things like that. So I'm definitely willing to take a look at that and send it over to Sam if she's interested in sending it to you guys.
Okay, thank you.
Yeah.
Are there any other questions? All right. Well, thank you, Amber, for being on the call, and I will share your contact information if folks have any other questions for you. But this was a great overview, so thank you very much. Have a wonderful rest of your afternoon.
Thank you.
All right, guys, this does it for today. So we will see you at 10 a.m. on Friday for our last session. So have a wonderful afternoon.
Thank you.